And if you're just clicking on that document, I'm going to start at COPD. So if you scroll down to COPD, that'll be the first slide that we do today. Okay, someone in the chat, give me a yes or thumbs up if you can actually see my screen. And the PowerPoint's coming through, sound is good, everything looks good. Okay, I think we're good to go. Let's go ahead and get started. So the first slide today is section is on COPD management. All right, so with COPD is kind of an umbrella term for several different conditions. So COPD is an umbrella term for more than one condition. It is a disease that can be prevented. It is treatable, but it is not fully reversible. It's a progressive condition. So once someone has it, they do have it. We can kind of keep the symptoms under control, but it is not something that we can cure or put into a full remission. It's not that kind of a condition. It is due to damage that occurs over time. What happens over time is there's airflow limitations coming out mostly due to small airway disease, inflammation, destruction of the lower parts of the lung tissue. It has a lot to do with trapping that air down in the lungs, especially when we're talking about emphysema. So the two major types of COPD, some researchers and physicians will argue that asthma is a third type of COPD. I find that to be a very interesting discussion. But the two types we're going to discuss today is chronic bronchitis and emphysema. So chronic bronchitis is a clinical diagnosis based off of the amount of time that they are symptomatic with these things, which would be a chronic persistent cough, lots of sputum production. And this typically occurs for 3 consecutive months per year. And this happens for at least 2 years. This one has a lot of exacerbation and remission. Whereas emphysema is the one that we're more familiar with when we think of COPD. You're probably thinking of this patient. There's permanent enlargement of the air spaces below the terminal bronchioles. So you've got bronchus, bronchioles, and then below that is where we see the enlargement of the airspace and destruction of the alveoli. We have blebs where the alveoli have no longer look like a cluster of grapes, but slowly kind of conflate and join together to create a single bleb. And that decreases the surface area of the alveoli drastically. You're going from the surface area of each individual grape to the surface area of a ball. And you have, if you laid out the surface ball of that, there'd be a lot more surface with the bundle of grapes versus the ball. So when we lose that space, we lose the ability to exchange CO2 and O2, and we also begin to trap air in that area. The issue is not necessarily getting air in. With the COPD or the emphysema patient, it is the getting the air out. So getting the air out. So when they can't get that air out, it gets trapped. It flattens that diaphragm down. It just looks funny. I had someone in the chat tell me they can't quite hear me. Is anyone else having any issues with that? Because if so, I can switch my microphone. Is anyone else having trouble hearing me? So I can switch my microphone. Thank you, Amber, for letting me know. Okay. Thank you so much. So let me know if there's any issues with audio and I'll switch that over. Thank you. So again, the issue is not being able to breathe out. When we can't breathe out, we're not able to let go of our CO2. And we can't let go of our CO2. We're not able to expel it. We're not able to breathe it out. It gets trapped, stays in the bloodstream, and then we end up with respiratory acidosis, a very, very acidotic environment when you look at their ABGs. So respiratory acidosis, and then that's going to compete, of course. We're not going to have oxygen on our molecules. We're going to be acidotic. There's lots of downstream issues from there. So let's talk about some fast facts with COPD when we're thinking about our population. How much does this affect the general population that we're treating? I can tell you tomorrow, tell you yesterday, I went and saw 4 patients. I do home health, and 2 out of 4 had COPD. One of them was end stage and was on oxygen. So the third leading cause of death in the U.S. and fourth worldwide is COPD. This is steadily increasing over the last 30 or so years. It's heavily associated with smoking, and it's heavily associated with the degree to which one has smoked. So there is environmental exposures that can cause this as well. There is a genetic predisposition for this as well. There's a genetic form of COPD in addition to just a predisposition. We'll talk about that one on some labs here in a minute. And those of a lower socioeconomic status. Morbidity and mortality is higher in Caucasians than other groups in the U.S., and more men than women die from COPD. So when you think of your COPDer, it's very often a Caucasian male, obviously not always, but that is a very common patient population that has COPD. Lots of smoking went on. You know, if you're thinking about them, they're 60, 70, 80 years old. You think about the work environment and the culture when they were in their 20s and 30s, and there was a lot of smoking, and so now you have this um, showing up now, all of these patients who smoked at that time. On clinical presentation and examination, what are we going to see the patient deal with? They're going to be short of breath. They'll have dyspnea of a chronic cough, meaning a cough that has lasted longer than 3 months. Any cough that lasts more than 3 months, we start to really scratch our head and kind of wonder what's going on there. We don't want to just keep dismissing it over and over again as, oh, you've got another flu, you've got another cold. There was a patient I saw a few years ago who came back to me 2 or 3 times with colds within a 3-month period. And the third time he came in, my stomach just dropped. I was like, this guy does not have colds. He had finally had enough clinical symptoms in addition to the colds for me to realize that he was like fluid volume. It was a fluid volume issue. He never had edema on any other examination I'd ever done. He didn't necessarily have any pre-existing conditions. He had never been in AFib while he was in the room with me, so we didn't know he had AFib. So it was just that he'd been coughing for more than 90 days and had cold after cold. For me to sit there and be like, we're not going to let this go on any further. I need to dig really hard. And so I did a very thorough exam. I didn't just do a respiratory kind of focused exam that you typically do in the setting I was working at the time. I just wasn't comfortable sending him home again after that. And his color was off. He just looked different to me this time. And I was like, if I don't do something now, we might miss something huge. It wasn't COPD. This is a testament to a 90-day or longer cough needs to be examined carefully. Because I was feeling his pulse, and it was bouncing all over the place, and I kind of put 2 and 2 together. He had some edema to his lower extremities. He had been going in and out of AFib. It had just never popped up while in the office with me. So he's in AFib, sent him over to the urgent care of the ER, ended up in the ER, got admitted. I was actually in heart failure from so that sound we were hearing in the lungs, the congestion, all of that was fluid. He had like a left-sided heart failure. And so instead of just sending him home again saying it's just another cold, I stopped and said, no, let's look at you very closely. The only thing you're complaining of is a cough right now. I need to know what's going on. But again, 90-day cough, look, is it heart failure? Is it COPD? Is it something like GERD? Because that can present with a cough. Um, so asthma as well can present only with a cough, no wheezing. So again, 90-day cough, chronic cough, start to look for something more than just being sick all the time, especially if they have any risk factors, they're older in age, things like this. Lots and lots of sputum production with COPD. What is their smoking history? Were they exposed to secondhand smoke? Does someone in the house smoke with them? So that's almost as if they're smoking themselves. Often we'll see so not everyone gets COPD that smokes. Why does this happen? Sometimes we'll find it in people who have more sinus issues, who had asthma or upper respiratory infections quite a lot when they're children, or had major pneumonias in their teens, 20s, 30s. For whatever reason, they're more likely to suffer from COPD just because they've had inflammation, irritation. They're predisposed to that kind of a problem anyway. So it's not surprising when that person tells you what their childhood was like. They had a lot of sinus problems and respiratory infections. And the dyspnea on exertion is they're not able to walk across the room without getting short of breath. Their oxygen kind of starts to dip. when they move around versus when they're sitting, they're able to keep their oxygen level um, a little more stable. And physical examination, what are we going to see on the patient? So we've got all of our information that we can kind of ask from them. What kind of things am I going to see on the examination? They're going to have that increased AP or anterior posterior diameter. And I always tell people we look like cheeseburgers. If you take our rib cage and pull us down like this, we look like a nice sandwich, okay? When they start to look like a donut, when we have become a barrel, that's what we mean by increased anterior posterior diameter. The ribs and the lungs have hyperinflated to make us more round. The rib cage is now round instead of sandwich. They also tripod, you know how you've seen as a nurse, they're in the hospital leaning over their bedside table with their shoulders pulled forward, their arms out in front of them to try to open up their chest so they can breathe better. Pursed lip breathing as well is common because exhalation is such a hard thing for them to do. They have to kind of push their air out. So they're trying to push their air out, and they have a prolonged exhalation. It should take you and I less than 6 minutes, 6 seconds to push all of our air out of our lungs. It should be gone. And somebody who has COPD, it takes them longer than 6 seconds to actually push. It's not just an exhale like you and I might experience, it's a push. They're pushing against that inflammation, the closing off of the lower airways. They're having to push their air out. And they also have clubbed fingernails due to the long-term lack of oxygenation to the tips of their fingers. What might we hear on them? Increased resonance with chest percussion, early inspiratory crackles. If you hear wheezing, there might be some congestion causing that wheezing sound, but we need for them to go ahead and kind of cough and clear that up. We typically hear wheezing more with asthma. This is a lower issue. Asthma is an upper issue, and asthma creates the wheezing sound, whereas COPD, if there is wheezing, we could definitely consider there's a lot of congestion. In the late stage, they might have heart failure, and they're more likely to have right-sided heart failure. So that would be, the JVD, edema, hepatomegaly. So it's the systemic, all over the body signs and symptoms of heart failure versus the lung sounds with the left-sided heart failure with all the fluid backing up to the lungs. With the right side, all the fluid backs up into the body. So diagnostically, we can do a screening test called a forced expiratory time. I don't see this clinically done. If you have, let me know in the comments or the chat section that you've actually seen this done before. But it's called the forced expiratory time. If you have a patient and you're in a setting where it's very education based and they're fine with you kind of experimenting, if you're a student right now, go ahead and test this out on a COPD patient, maybe one that's already been diagnosed, so that you can kind of test and see how long it takes for them to exhale. So what we do to complete this test is we observe the patient while they're exhaling. We have the patient keep their mouth open. We're going to listen to their trachea and we're going to time their exhalation and listen. If there's still sound, still breath coming out after 6 seconds, we would consider that a positive finding. And you could chart that as an indication of why you're ordering spirometry, which is the true diagnostic test. That would just be a screening exam. We would want to do a diagnostic test with using spirometry. You also want to get a chest x-ray of both AP and lap. You'll see a flattened diaphragm. You'll see that increased AP diameter. And for your labs, you're going to want to grab a CBC with DIF. You can get ABGs. And you also would want to check an A1 antitrypsin, especially in the absence of a smoking history or a young age. This is a genetic form of COPD. I actually had a peer who had this in her family. It was genetic. So one of her family members had passed from it at a pretty young age. And I believe she also had positive A1 antitrypsin, but did not seem to have as many issues as the other family member. But it was genetic. It did pass through the family, and it causes COPD, again, not related to smoking. How do we quantify what is going on with our patients other than spirometry alone? We can use several pieces of information. We can take the patient's subjective experience and kind of turn that into a number so we can make it quantitative by putting it on a scale. This scale is commonly used, the CAT. This is another scale that we can use, the MMRC, to help quantify their subjective experience. And then we can also look at their spirometry as well as have they had exacerbations or hospitalizations. So we're taking all the information, both subjective and objective, quantifying it and using that to group them. And we will talk about some of the changes in grouping recently because within the last couple of years, about less than 2 years ago, we made a transition from groups A, B, C, D, which you are commonly still seeing in your textbooks at this time, to A, B, and E. I'll talk about the differences, why I think that's a good switch, and what that means for you as far as testing and clinical experience. So let's look first at this assessment. This is your CAT. Again, the patient you're giving this to them while they're sitting in the waiting room so that you can get some of this information ready to go by the time they're in there in the office room with you. This is based off of coughing. Do they feel like they have a lot of phlegm, chest tightness? How breathless are they when they walk up a hill or stairs? How are they managing their ADL? Can they leave their home, or is there concerns there? Is there any sleep issues? Are they having any energy issues? So they can scale it there. This one's a lot more simplistic. This one is you pick a 0, 1, 2, 3, 4. That's it. It's just one question. It's all about breathlessness. You look at that. I get breathless with strenuous exercise, which is to be expected, all the way down to I'm too breathless to leave the house, or even getting dressed makes me breathless. And so that would be the most severe grade of dyspnea. Next, we can look at the spirometry grading system. There's mild, moderate, severe, and very severe. So think of it as goalposts. Put this in your mind. Your goalpost for your FEV1, which is the number I typically pay attention to, I'm going to think about 50 and 80, and I'm going to kind of put everything between those or around them. So greater than 80 is mild. Between 50 and 80 is moderate. Less than 50 is severe. And then very severe is less than 50 but also needs oxygen, which is chronic respiratory failure. Now, to the point at which you can say someone has chronic respiratory failure is the point at which they become oxygen dependent. And then next, we would take all of that information, the CAT score or the MMRC, their spirometry, mild, moderate, severe, very severe, as well as exacerbations and hospitalizations, to put them in one of these groups. We've got group A, B, C, and D. Looking at group A and B, these guys go together. They're low risk. Groups A and B are low risk. Group A feels less sick. They haven't had exacerbations or hospitalizations. Group B, they're still low risk. They're not, and now we're not going to put them on oxygen next week. They haven't been to the hospital, but they feel more symptomatic. This means this is someone who is possibly getting worse. It also means it's possibly somebody who is not being well controlled with their medication, not taking their medication properly. It could be any one of those reasons why they feel more symptomatic. But we still call them low risk because their FEV1 is good and they haven't been in the hospital. They haven't had any major exacerbations, needed antibiotics. With group C, this is the high risk, less symptoms, and this is usually the gold 3s or 4s at this point. So high risk, less symptoms. Group D, high risk, more symptoms. So you can see how they've grouped it. You've got your ABs, which are low risk, and your CDs, which are high risk. It's all about how they feel, what their symptoms are. So with group C or D, they have been hospitalized, they've had exacerbations. C feels more controlled, less symptoms. D feels less controlled, more symptoms. Now I'm going to skip forward to a few slides to show you why they combined C and D before we talk more about some of the medications. They combined C and D, and to me, that makes a lot of sense. I don't really care how you feel. If you've been in the hospital for COPD, if you've had 2 exacerbations where we've had to put you on antibiotics, put you on oxygen short terms, anything like that, where you've had an exacerbation, I'm concerned and I want to treat you the same whether you feel under control or not. So I like the idea of combining C and D together to create E. With A and B, that can kind of make sense for me. With A and B, we're already low risk. I'm not concerned about you needing oxygen next week. I don't think you're going to go to the hospital next week. But I am curious to see if you feel controlled or not, because that can kind of help me gauge where we are. If we've hit the high risk point where we are having hospitalizations and exacerbations, I'm more concerned. I want to treat you more aggressively and that type of thing. Another change they made with those is they did kind of fix those gold 1s a little bit. Your goalposts are very, very similar, but they dropped the severe, the gold 4. They started it at 30 and saying less than 50, but also with chronic respiratory failure. They just dropped it down to 30. So that's what they've done to kind of adjust the gold 1, 2, 3, 4 staging. So what does this change as far as treatment? It's just a more aggressive approach to those two high riskers. So let's look back at the previous slides where it talks about medications that we can use for these groups of people. We want to start them off on a bronchodilator. We want to always keep that on hand for the patient, but we'll start them off on that bronchodilator. Typically, we're going to start them off on a SABA. Once they've moved to group B and they're more symptomatic, we can start using a long-acting beta agonist, or we can use a long-acting muscarinic receptor antagonist, the LABAs or the LAMAs. Once we've moved to group C and D, we can start any of the other medications, the LAMAs, the LABAs, the ICSs, or any combination thereof. We have lots of different options as far as combining LABAs. We've got Urolipta, you've got the Respimat, the Duaclear, so you've got lots of options there for doing combo inhalers. And as a last resort, again, the last thing we want to do is put the patient on oxygen. We want to wait as long as we can, because once they're on it, and they're going to become more and more dependent on it. Remember, it's a problem of exhaling. It's not a problem necessarily of getting oxygen in. But at some point, that mismatch gets so high, we need them, what they're breathing in, to be very, very oxygen rich. But all it's really going to do is put more air in, which can allow more air than to be trapped. So it can progress things more rapidly once we put them on the oxygen. So we want to be very cautious in putting them on oxygen. If a COPD patient is in the hospital, you may notice as nursing is we don't want to crank it up while they're in the hospital with a pneumonia or an infection or anything like that. Let them run a little bit lower, because we can't crank up the oxygen all the way because of these issues, because of the air trapping, because it's a slow progression of dependency once they're on the oxygen. So what is an exacerbation? So it is a condition, a time when there is increased dyspnea, increased sputum, more sputum purulence. So there can be bacteria, it could be viral, it could be a pollutant, and it increases the already inflamed airway. And this creates a cascade of greater airway inflammation. So the COPD itself gets worse, and we possibly have an infection that needs to be treated. And it can create systemic inflammation. It can affect the heart, and it causes all that bronchoconstriction, edema, mucus, and this, of course, again, creates an expiratory flow limitation. We're not able to get the air out. Lots of hyperinflation, all of these symptoms coming to a head. Increased dyspnea, oxygenation levels going down, respiratory acidosis. The bacteria that are commonly at fault here are S. pneumonia, H. influenza, C. pneumonia, and M. catarrhalis. So that's some positive, negative, and atypicals. We like to use things that are broad spectrum. We often like to give it a 1-2 punch to help, one of the antibiotics is breaking down the cell wall, the other one's going in and doing something else. So they can kind of work together to increase the chances that we get rid of this bacteria. We can choose from things like amoxicillin, augmentin, doxycycline, Bactrim, or azithromycin. Amoxicillin's probably not preferred. Azithromycin is a good one if you're also using something like augmentin. Those two like each other, but alone azithromycin is pretty weak. So let's look at the x-ray for this patient. So on the left, we have a normal patient who has a nice curvature to their diaphragm here. You can see that there is not this distension, the barrel chested. And this patient over here, we have progressed COPD. We have a flattened diaphragm. You can see that very clearly on the lateral, where you can see that flattened diaphragm as well as that barrel chest with that great increase in the diameter of their chest. Okay. All right, let's move on to thyroid disease. We're going to talk about both hyper and hypothyroidism, but primarily as if you're a family nurse practitioner in the primary care setting, you're treating hypothyroidism. Hyperthyroidism is a little bit more difficult to treat and typically needs to be seeing an endocrinologist. So here's this picture. This is an old NCLEX picture, but I love kind of reminding you of what those two conditions look like. Hypothyroidism is the dragged down cold symptoms. So we're intolerant to cold, losing hair, facial edema, very fatigued. The tongue thickens a bit, no appetite, but we're still gaining weight. The metabolic rate changes greatly. So even just the food that's being consumed, it's not being metabolized correctly. So we end up with that weight gain. Constipation, again, everything is slowed down. So constipated, lethargic, dry skin, weakness generally, and then menstrual disturbances, but that can occur with either. If there's some later clinical manifestations, it's not being treated. They're very progressed in their condition. They can even have the heart rate kind of slow down, the very low body temperature. With hyperthyroidism, this is a very hot, it's hot. It's everything's cranked up, heart rate's cranked up, the stomach's cranked up, so we have diarrhea, losing weight very rapidly because the metabolic rate here is increased quite a bit. So again, tremors, shaking, amenorrhea. They're hot, sweaty, very fast heart rate, very anxious because of the fast heart rate. When the heart rate increases, the fight or flight kind of kicks in almost in a backwards way. And, you think you're running from a bear, even though it's just your thyroid's mad. So what are the risk factors here for these two? We've got hypothyroidism. That's the patients with Down syndrome. A good portion of patients with Down syndrome have hypothyroidism. I think it's something like 40%. As we age, we're at risk for thyroid disease with hyper and hypo. Females are more at risk for thyroid disease. Postpartum women, especially if they've had quite a few kids, maybe back to back, can have hypothyroidism. Family history, it's genetic, runs genetically if they've had radiation to the neck. And then autoimmune conditions love each other. Most hypo and hyperthyroidism are caused by autoimmune conditions, not all, but most. And so if you have another autoimmune condition like lupus, RA, shortened something, something like this, it's not uncommon that these things kind of breed together. In hyperthyroidism, one of the differences there is only lithium causes it of the medications. With hypothyroidism, iodide, amiodarone, and lithium can cause thyroid disease. Hypothyroidism. I've seen amiodarone-induced hypothyroidism. Don't change their medication. If you find this, so if someone's on amiodarone, been on it for a while for their heart, and you find that their thyroid levels are dropping, you need to reach out to the cardiologist. That's not a medication you can probably safely transition on your own without having a full understanding of that patient. They might also be seeing EP, so you don't want to mess with their medications unless you want a very angry phone call later. So leave it alone. That is the cardiologist's job to change that rapidly to get them off the amiodarone and onto something else. The amiodarone can damage the thyroid over time. Who do we screen? We do not routinely screen for thyroid disease. I do know lots of doctors and nurse practitioners do routinely screen for it, but I mean, look at the patient population we're talking about. We're overweight, we're tired, we're fatigued. So we would love to attribute it to a thyroid problem, so we check on that pretty frequently. And in reality, we need to sleep better, put our phones down, exercise, eat whole foods. But sometimes it is thyroid disease, so we end up screening for this a lot. There is a lot of thyroid disease going on. It could be attributed to lots of different things in the environment that could be contributing to that. What kind of labs do we need to do? So this is where it all kind of makes sense to me. So what happens with hypothyroidism is the thyroid itself has turned off. It's shut off. It's not making T3, not making T4. It's just sitting there quietly. And so the brain is up here saying, hello, wake up, thyroid, wake up. So the brain is producing a significant amount of the stimulating hormone, the TSH. So the TSH is really high, trying to wake up the thyroid, which is too sleepy. It's not going to do it. It doesn't matter how much TSH the brain spits out. The T4 is going to stay low. Okay? So that's your hypothyroidism. Now let's flip it. With hyperthyroidism, the thyroid has taken over and it's just shooting out T4 like mad. And so the brain says, okay, I don't need to do anything. I'm just not going to make any TSH. That's obviously good on its own. It's making all this extra T4. So thyroid puts out lots of T4, so hyperthyroid, and the brain's not making any TSH, so we've got a low TSH level. So hypothyroidism increased TSH, low T4, typically caused by Hashimoto's, which is an autoimmune condition for which we typically have a genetic predisposition. We'll also see this in women between 30 and 50 as age of onset. That's when we're females, we're fertile, we're having babies, so that's you're more likely to be postpartum in that time as well. They might have a goiter, they've got all those dragged down symptoms, and you would manage that with levothyroxine, which can be started two different ways. You can start weight-based or you can start dose-based and titrate it up. Uh, with the elderly or those who have heart disease, you must start at a low dose and titrate it up. I don't really see weight-based being done either. If you actually start doing some of the math, if you have a patient next time you're in the clinic, look at what their dose is for their thyroid medication and then do the math for the weight-based dosing. Not all the time, but most of the time, the weight-based would give you a higher dose than what they're actually taking. And their labs are good, they're therapeutic, they don't have symptoms. So with the weight-based, I think you end up with higher doses unnecessarily. And so a lot of people just do start at 25 or 50 and titrate it up until it's therapeutic. We have to be very careful in educating our patients who are taking levothyroxine or Synthroid. They need to take it at the same time every day on an empty stomach, water only. We want them to have it right there at their bedside. So as soon as they wake up, it's the first thing in their mouth so that they can wait that hour until they eat. We also typically don't like for them to change brands. So Synthroid is the brand name. We put a lot of patients on Synthroid specifically because it will never change the formulation. Generics kind of change their formulation here and there, as well as pharmacies change which generic they're sourcing from time to time. And that alone can mess up someone who's been stable for a while those medications have to be 95% similar to the brand, all generics need to have 95% similar bioavailability to the brand, something close to that. But again, those little changes, people with thyroids can be very sensitive. This thyroid condition, hypothyroidism, can be very sensitive to changes. So sometimes you have to keep them on the Synthroid. Some patients don't tolerate this very well. They might go on a goitrogenic diet to try to help. So they're avoiding certain foods that are goitrogens that can contribute to hypothyroidism. So they might try changing their diet. They might try Armour thyroid, which is porcine. They can also try, that's an alternative holistic approach to replacing thyroid, replacing that T4. We want to check them every 4 to 6 weeks. Any sooner than that, it won't really show much of a change. They should start to feel better pretty quickly, though, if it is the right dose and right formulation for them. And we're going to recheck them every 4 to 6 weeks until they're therapeutic, and then we can recheck them every 6 months to a year, depending on their symptoms or how stable they seem, as far as do we need to adjust their dosage one way or the other, because sometimes you actually decrease it. With hyperthyroidism, this is caused by Graves' disease. I always tell myself up out of the grave. We're coming up out of the grave, up. So hyperthyroidism. And we see this in younger folks. Autoimmune conditions typically pop up in the early 20s, especially in females. So the age of onset for this condition is between 20 and 40. On a thyroid scan, they'll have a hot spot where there's an area of increased metabolic activity. That's actually the part of the thyroid that is shooting out all this extra T4. They have all those hopped up symptoms we just talked about. How do we treat them? We want to kill the thyroid or suppress it, so to speak. We're going to use methimazole or PTU until they reach what we call a euthyroid, good thyroid status. Some people stay at that euthyroid level and we don't do anything else for them, but other times some radioactive iodine will be given. This is actually going to kill off the thyroid more permanently rather than just kind of suppress it. And so it will create hypothyroidism, which in general seems easier to treat. Hypothyroidism doesn't really cause a lot of major events that lead to hospitalization. It can, but with hyperthyroidism, going into a thyroid storm can be very lethal. The blood pressure is incredibly high. The heart rate is incredibly high. So we get really worried about that with those patients. So thyroid cancer. So if you palpate the thyroid, right? That's part of your annual examination, is you feel around their thyroid. If you find a node, it's a single, non-tender, immobile node, it's sticking. We don't like things, cancer sticks. The risk of that being a cancerous node is only about 5%. So that is some comfort to offer your patients. If you do find a node that you want to do a scan on or order or send them off for biopsy or something like this, again, only about 1 in 20 of those will actually come back as a cancerous issue. What are the risk factors? What do I need to tell my patient as far as this is more likely to be cancer than not? Who am I worried about? They don't have hyperthyroidism, any signs of that. Because hyperthyroidism, you will feel nodes, okay? Irradiation of the head and neck. If they've got pain or dysphonia, changes in their voices, they're coughing up blood, lymphadenopathy, or a hard fixed mass, something like this, all of that is more concerning. So regardless of what kind of symptoms you see, let's do a thyroid scan and a needle biopsy. Lastly, we're going to talk about iron deficiency anemia. And first, I need to run to the restroom really quick. I'll be right back. All right, we're good to go. I didn't want to stop in the middle of that new topic. All right, iron deficiency anemia is a microcytic hypochromic. Without giving the full lecture, usually I start this section off in my full review, kind of breaking down what all the different labs mean. So to give a short version of that, microcytic would mean a small cell. Hypochromic would be a more pale cell. It's the most common type of anemia out there. You're going to run across this all the time. When you've got the fatigued female, check for iron deficiency anemia. It's diet related. It's related to our menstruation, our heavy bleeding. So there's a lot of predisposition there in the female population for iron deficiency anemia. What kind of other symptoms might you see with this patient? Definitely fatigue, but pallor and exertional dyspnea. I have been anemic 2 or 3 times in the past 10 years or so. I do tend to have heavier cycles, and I can tell when I'm becoming anemic again. At this point, I just take iron pretty much all the time because it has happened enough times for me to think I should just continue to take iron supplements fairly regularly. But during those times when it was kind of coming and going, the exertional dyspnea was the hardest part for me. It was pretty significant, and I would just be like, I can't catch my breath. I don't feel like I can take a deep enough breath to feel fully satiated. I was like oxygen hungry almost during those times when I was anemic. I never got to the point of anything like glossitis or angular cheilitis or pica. Those are some rarer symptoms, but most people will have the fatigue, the pallor, and the exertional dyspnea. If it's a very severe iron deficiency anemia that's been going on for quite some time, we would be concerned about polyneuchia, the spoon-shaped nails, murmurs in the heart, tachycardia, or heart failure. So what kind of goes on with the labs as well? We're going to look at a few things in the labs. Ferritin, this is the stored iron. Then the transferrin and the TIBC are the other two we're going to look at, and that's the car. That's the driver that moves the iron around the body. So in the early stages of iron deficiency, there is a depletion of the stores. So we have all of our stored up back shelf overflow stock in the back. That's our ferritin. So in the early stages, we start to burn through the ferritin. So there's still enough iron in the blood. So the serum levels of iron in the blood look normal, and there's enough in there to make the red blood cells. But over time, again, that ferritin, the stores, the backup is being used up. So serum looks normal, ferritin is low. this, they might start to be a little bit symptomatic here, but they're also definitely impending major true iron deficiency anemia, because once all of that stored iron is used up, the body is going to start trying to compensate. It's going to create a lot of the transferrin. It's thinking, oh, I don't have enough cars to pick up the ferritin that should be there, or iron that should be there. And so it starts to increase the transferrin in the TIB-C um, to go pick up more iron, but there's no iron there. So that's why that starts to increase kind of in an odd looking way. So the transferrin TIB-C increases, ferritin's already low, and now as it progresses, iron in the blood levels become low as well. So those are all the different labs that you're wanting to check. You're doing your CBC to look at their H&H and their NCV, MCHC, and all those. But when you do the iron panel, you want to get the ferritin, the transferrin, the TIB-C, and the serum iron level itself to see at what stage they are. So again, early, just ferritin looks low. As we go later and later, the transferrin and the TIB-C increase to try to compensate to go pick up more iron. Again, there's not iron to be gotten. And then lastly, you're going to have that serum levels drop. And because of this, you're going to have that MC, HC, and MCV will decrease at that time, because you're going to have small pale cells. You don't have enough iron to make healthy, happy cells. So that's that MCHC and MCV will decrease. The size and the color go down. Pale and small, not happy, won't carry oxygen well. So again, what are the causes? Think menstruation, GI bleed, peptic ulcer disease or a trauma, some cancers, poor diet if you're not having good dietary intake. Pregnancy is more of a dilutional, so you end up with a lot more blood volume. With the same amount of iron, it will cause a dilutional iron deficiency anemia, but it still is often symptomatic. If you're looking at boards, and there's a little question on there that says, if they're less than 1 year old, consider it to be cow's milk. Children under the age of 1, if they're being breastfed or they are drinking formula, should not have iron deficiency anemia. If they do, somebody's probably giving them cow's milk. Interestingly enough, calcium chelates iron, and so it would bind it up and make it not absorbable or usable. And so the iron that the child may be getting from other food sources is going to be bound up by the calcium in the cow's milk, and it will give them iron deficiency anemia. We don't want children under the age of 1 using straight cow's milk. If a pediatric patient under the age of 12 or 13 has iron deficiency anemia, it's most likely a dietary concern, eating just like a carb heavy with no supplemented foods or anything like that. It'd be pretty hard, because even cereals these days are supplemented with stuff. Labs, again, low H&H, low MCV, MCHC, ferritin and iron, and then increased transferrin and TIB-C. How do we treat this? Good old over-the-counter 325 ferrous sulfate, Fe, over-the-counter is fine. We want to do that for at least 3 to 6 months, because we need to not only replace what's in their blood to make them start making happy, good cells straight away within like the first 2 weeks of therapy, but we need to rebuild their stores, their ferritin. And that can take 3 to 6 months to rebuild their ferritin stores. We want to also look and see what's going on. Why did you become anemic? What kind of issues can we address? Are you having heavy menstruation? Was there a GI bleed? Was there a peptic ulcer? What's going on? What's causing the problem? So treat the problem, and then also give them replacements to rebuild their stores. So again, textbook traditional classic way is just cheap over-the-counter ferrous sulfate to replace it. That can cause a lot of constipation. There's a couple of different formulations out there that I like. You can always do slow FE. That one is more slowly absorbed and causes less constipation. Or you can do blood builder. Blood builder is pretty cool because it's got some other supplements in it. When you take iron, it's very important to take vitamin C with it as well. And blood builder has vitamin C and then a couple of other supplements in it as well that are very beneficial in rebuilding your blood supply, basically your body's own backup from the ferritin and such. So again, we want the patient to take vitamin C. We want them to avoid taking antacids around iron, because antacids typically are calcium, like calcium carbonate or something like that. We don't want to chelate up the iron and make it unusable. So no dairy, no antacids. We don't like it near antibiotics either. Can't remember why. That's probably, I don't know, probably something in the liver. For best absorption, again, take it with vitamin C or orange juice. Black stools are a normal side effect, constipation, GI upset. If they do need to take it with food, just make sure it's not a calcium-rich food. They have to have something on their stomach in order to tolerate it. Will cause their FOBT to also be falsely positive. So if they're of that age, 55 to 75, and you're trying to do colonoscopy or FOBTs, the FOBTs can be falsely positive when they're on their iron. So what's a classic case here? We got a 42-year-old office manager who presents with fatigue and weakness persisting for 6 months. Physical exam reveals pallor. Their conjunctiva are pale. They have microcytic hypochromic anemia. On labs, they've got decreased iron, elevated total iron binding capacity, that TIBC, and decreased ferritin. We're going to diagnose them with IDA due to chronic blood loss, likely from her heavy menstrual periods. We're going to treat her with ferrous sulfate 325 for at least 3 to 6 months, gynecology referral, dietary counseling of foods rich in iron, and we'll follow up with her. So we educated this patient on iron-rich foods and encourage compliance with the supplementation regarding timing, making sure she doesn't take it around the wrong things. If someone is having a significant amount of GI issues with their iron, you can take it every other day, and it will still increase the stores. 3 to 6 months, at least every other day, it will still replace the stores. It does not have to be taken every single day. It will still work on an every other day kind of a basis, especially because the slow FE and blood builder are a little bit more expensive. So if you really need them to take iron, we need it to be a bit cheaper. They're having a stomach upset, take it with food that's not calcium rich. Take it every other day, and possibly take a cheap stool softener or increase your fiber to try to mitigate all those other things that are kind of going alongside of it. All right, so if you are interested in doing a full course with me, it'll be an 8-hour class. I'm open for registration for February. We've already finished January. Those dates have passed. So the expert FNP review course is in February. There's the link for that there. Those of you who already grabbed the PowerPoints from me earlier will have that link. If not, you can find that on my website, www.np-guide.com, and that's a dash, not the word dash. And you can find the registration for that there if you want to do a full class with me to help you get ready for your clinicals, your boards, or practice. I think all that information is overlapping and can be very helpful at any point during your education time. So if anybody has any questions at this point, I'm happy to answer questions from you. I'll probably take the live stream in a couple of minutes. But again, if you have questions right now, please go ahead and ask them. And this is up on YouTube, so you can go ahead at any time and rewatch it later. All right. I hope you guys have a wonderful, wonderful rest of your day. I look forward to seeing you next week. Next week, we're going to do what we call bridge. This is where I will talk about what are the next steps you should be taking if you are done with all of your classes and it's time to not only just study for boards, but what kind of things should I be doing to prepare for my career? So this will be more of like a career coaching session to talk about contract negotiations and licensure, just what are the next steps? Because a lot of times you finish schooling and you're like, okay, well, now what? Because there's lots of steps. Should I get my DEA? Should I get my NPI? What are the steps that I need to take? And so we'll do that next week, next Wednesday at 4 o'clock Eastern Standard Time. I'll be live on Zoom as well as YouTube. And I look forward to seeing you guys next week. If you enjoyed this and you're watching me on YouTube, make sure that you leave me a comment telling me what you learned today, the most interesting fact or question that you have, something that you want to see in the month of February, and as well as make sure that you're subscribed so that whenever I start going live, anytime that you may not know about, you'll get a notification. So you can either watch it live at that time or bookmark it to save it for later and watch it. So again, I hope you have a wonderful rest of your day.